Good morning and welcome back to Extension and Engagement Week. We're really glad to have you here today as we begin this third day of this exciting week to celebrate extension, engagement, and outreach for the University of Missouri, University of Missouri System, UMKC, UMSL, and Missouri S&T, as well as our partners across the state of Missouri. We're excited today to again recognize our sponsors, the people that have really made this possible, and in particular today, the Missouri Hospital Association and Hoosh Blackwell, who again work with us to ensure that we are able to provide this kind of program, not only for those who work internally with the university, but all of our stakeholders and our partners across the great state of Missouri. We ended yesterday with wonderful presentations. Dr. Dwayne Proctor shared with us some insights from the Missouri Health Association, and we appreciate his insights, and we welcome him to Missouri. Opportunity for him to be a part of us and to join us now as a partner in this great work. We're also excited that Dr. Francis Collins with the National Institute of Health was here. What an esteemed individual to be with us and to be a partner again with us as we think about the urgent needs that we have in health inequities and disparities in our state, our society, and yes, our country. These are big issues and they will not be solved, and definitely people have been working on them for a very long time. But we are happy to embrace those and to figure out ways, again, with our partners that we can be a part of the solution, not only for Missourians, but for all citizens of this great country and of our world. We know the cost of not doing so, it hurts our economy, it hurts all the aspects of our world. And you know, when I think about our communities, our neighbors, and the people we work with, the people we care about, health is so central in all of our lives. And it doesn't matter who you are or where you sit today, you have been affected in some way by a healthcare crisis. And it's important for all of us to understand that it will affect our lives at some point. And these kinds of conversations help create the solutions that help us navigate those turbulent waters. So again, I want to bring it back home today. We're going to be talking about specifically Missouri. We're going to look at our state, our citizens. We're going to think about the items that are going on here in the state. And the lens we will look through will be, again, the state of Missouri. We're excited about the people that we have joining us. And just as we have focused in the past years on broadband, on workforce development, this year, it's all about health. And you know, when you think about the pandemic and all the things that have happened in the past year, definitely we have seen in full view the importance of health inequities, and all the issues, again, that are so incredibly important to all of us as Missourians. So today, I'm very pleased to go to my partner here on the set, Sarah Traub. Sarah serves as our MU Extension Director of Education Impact. She also is our primary liaison to work between the campus and communities on those stakeholder initiatives and projects where we're able to bring the full university into community. So at this point, I'll give it to Sarah Traub.
Thanks, Marshall. Engagement is at its core about relationships. Whether we're talking about addressing community needs around high-speed internet, finding capable workers, or addressing health needs around COVID-19 or diabetes, HIV, or mental health. We heard that message shared so powerfully yesterday by Dr. Proctor and the panel of Missouri experts who began laying out just what kinds of transformations are needed to accommodate all communities in movement to improve health. Here's one great example of what that can look like. Let's take a look at this UMKC collaboration with churches serving Kansas City's Black community and watch effective engagement in action.
Today, we're going to be testing in our parking lot. Amen. So all those that are there, all right, that are listening, all right, you are able to come. We're in our parking lot starting at 11:30, starting right now. Amen.
This project, the Faithful Response to COVID-19, is really focused on increasing COVID-19 testing in the African American community, and particularly in the African American faith community. This is really important because we know that the African American community has really been hit hard by this pandemic. As a matter of fact, we know that African Americans are more likely to be hospitalized and more likely to die because of COVID-19. So in partnering with our African American churches, we really see this as an incredible opportunity to not only make COVID-19 accessible, but also to work within the structure, the trust, the history of the Black church to motivate people to get tested.
The educational material that we've been provided, all that we have taken forth, we have with responsive reading, statistics, just being able to show the impact that it can have. It has been very well received in our community, not just in our church, but in our community outreach-wise.
In Kansas City, we are experiencing many of the same COVID-19 disparities as other African Americans nationwide. We are in this together.
As a physician, I can make recommendations, I can try to educate and explain, but that hasn't worked as well as we would like. But what we found is in our faithful community, where patients feel a part of their faithful family and faithful community, and they already have that trust, that by partnering with churches and by leaders, faith leaders, that our patients are more likely to follow in their footsteps and to hear the same message, but it's from someone that they trust.
I think something just like this, collaborating with trusted, traditionally, historically known institutions like the church, to be able to communicate correct information, to be able to partner in how to make these types of services like COVID-19 testing available for when people are available, and to also make sure that people know that in coming to their church, it's not only about being fed religiously and spiritually, but that their health is important as well. And so these types of health and church partnerships can be really important in that effort.
Partnering with UMKC has been it's been great, but because of the fact when we're I used the fact that there were all of the churches that were chosen, and so many that there were like how many that are in this study, and that we were blessed to be one to be a part of this study. It makes them know too. They can also see how we matter and how what we can do as a congregation, as a people, in helping each other, helping us.
UMKC has, an incredible position in the community. We are an urban institution, and sitting right in the middle of our urban community, we should be doing this type of work. We should be doing the type of work that not only engages our community, but increases their capacity to address the needs of the community. Right now, we're focused on COVID-19. There'll be something else right around the corner. So we're not only using this approach for this pandemic, we're using this approach to address diabetes. We've used this approach to address HIV. We've used this approach to address mental health and many of the other health disparities that affect our African American community that sits right in the heart of where UMKC is located. Engagement is about relationships. You cannot do engagement without relationships. And to have relationships, you have to have trust. And so engagement is a process. I mentioned earlier that we've been working with our faith community for over 15 years, almost 2 decades. Over that time, we've been able to develop trust. They have to trust us and we have to trust them, because this is a lot that we're really kind of putting in their hands. And so it's that mutual trust and respect. And to me, that's what engagement is all about.
So as you leave here today, amen, ask that you will go to your cars and that you will drive around and that you will be tested. Amen, that you will drive there, right there in our parking lot now, right there. And don't worry, it's not scary. Amen. Everybody like, ooh, no, it's not scary. Amen. Amen. All right. How great is our God? Sing with me. How great is our God? Oh, sing how great. How great is our God? Oh, sing how great.
Wow, what a wonderful example of engagement. I want to salute our friends and colleagues over at UMKC for the wonderful work they're doing in community to really be a great example of what we talk about, what we mean when we talk about community engagement. It's effective. It involves the community from the start. It begins with them identifying the challenges and the barriers, involving the key stakeholders to collaborate respectfully and to open up real solutions. That is a great example of what we're trying to do, not only at UMKC, but across the entire system as we think about extension, engagement, and outreach. You know, all of our healthcare system and their challenges have been a spotlight this year in particular because of all the challenges that have been put in front of us by COVID-19. More than ever before, it is a time to talk about the social determinants that affect individuals and communities in terms of their healthcare access and outcomes on a daily basis. To get us started with that conversation, I'm very excited to welcome a newcomer to Missouri, Donald Kaufer. Donald comes to us today as the director of the Missouri Department of Health and Senior Services, where he started his role in September. He'll be introducing our speaker, but before he does, let me just give you a little insights on this newcomer to Missouri. You know, I met him, I'll say as a sidebar, at the state fair. He actually was here in August, getting to know the state, getting to know some folks, and had the opportunity to have a conversation. And I can tell you I was excited to see him coming to take on this incredibly important role as we think about the health and the well-being of Missourians. He comes to us with 30 years of experience in state government, having served in senior leadership positions in public health, emergency management, most recently in the state of Illinois. During his time with the Illinois Department of Public Health, he developed a statewide structure to improve communication between the department, local public health agencies, and directed the development and implementation of the nation's first statewide pandemic influenza exercise. Great accomplishment and something that I know that will benefit from those experiences as he takes this role. Don, I want to thank you for being with us today and looking forward to future partnerships and helping us as we kick off this next conversation.
Thank you, Marshall. Yeah, this is quite a time to come into any state to be the state health director. With COVID overshadowing us now, it's nice that as a state that we are looking at issues such as what we're going to talk about, which has been the focus of this extension service, looking at those public health programs that, getting us back to the grassroots public health and some of the important issues. So I appreciate for being invited to do the introduction here. Without further ado, I'm pleased to introduce lifelong St. Louis health and racial justice advocate Bethany Johnson Jabwa as the keynote speaker. This has really been interesting. As I was preparing for the introduction, I was reading some articles about Bethany, and what struck me were some common themes that people, her peers, said about her. And I noted these. I kind of wanted to, this is maybe kind of an odd introduction, but the things it noted were unwavering faith, compassion for people, impactful decision-making, ability to work with candor and grace at the same time. That's a powerful, powerful word to say about someone. But Bethany was born and raised in St. Louis County. She returned to, as just recently, we're talking just right before we started, as the CEO and president of the Deaconess Foundation, has formerly served on the foundation's board of trustees. Bethany leads the foundation in its continued pursuit of the improved health in the metropolitan St. Louis community and the people through advocacy, organizing racial inequities, and policy change. Bethany formerly served as the CEO of the St. Louis Integrated Health Network. She led the nonprofit in serving the region's safety net healthcare providers and a local community to promote the mission of providing quality, affordable, accessible care to all residents of the metropolitan St. Louis, and with the emphasis on the medically underserved. Under her leadership, the network was chosen as the St. Louis America's Advocacy Organization of the Year in 2012. Her leadership in healthcare sector has garnered notable recognition, including being selected as the Mental Health America Eastern Missouri as the 2016 Silver Bell Award recipient for outstanding community service, leadership, values, mission, and also being selected as the St. Louis Children's Hospital's 2015 Community Advocate of the Year. She's included in the St. Louis Business Journal 2015 class of diverse business leaders and received access to Equal Justice Award from the Washington University School of Law's clinical education program. She possesses over 15 years of experience working and volunteering in the nonprofit sector for organizations that positively impact the quality of life for disadvantaged populations. Her expertise lies in developing strategies and transformation systems that be more responsive and equitable for the people for whom the public systems are accountable to serve. Bethany is a notable motivational speaker, trainer, and facilitator around spiritual development and leadership. Bethany was named the managing director of the Ferguson Commission in 2015. The Ferguson Commission is an independent volunteer group that was charged with addressing the underlying root causes that led to community unrest in the wake of the Michael Brown death. After the comprehensive study that included extensive community engagement, the commission published an unflinching report of its findings and almost 190 calls for action that charted a new path towards healing a positive change in the residents of the St. Louis region. It is my privilege and honor to introduce Ms. Bethany Johnson Jabwa as the keynote speaker for the first session, All Things Health. Thank you very much.
Oh, good morning. And thank you so much for the lovely introduction. And good morning to everyone that I can see and to those that I can feel and to those that I know that are in the audience. It is a great day to be alive. It is a great day to be well. And as you know from your conference materials, the topic that I have chosen and was called to speak about with you today, not to you, this will not be a 30-minute lecture, but with you today, will be Missouri's unfinished business. So first, before I start, I have to say thank you to the organizers of Extension and Engagement Week. It is an honor to be with you and to be selected as your keynote for today. I plan to ask you some questions to probe self-reflection this morning. So if you haven't had a chance to do so already, I'm gonna give you a quick minute to grab the coffee. Don't forget your water, grab your tea, and something to write notes with, because this is something that I'm hopeful that you will want to revisit from time to time in this discussion. The tagline, as I registered as well for the conference, that caught my attention was, quote, connecting to improve Missouri's economy, education, and health. And the most critical of all the words that I saw in that tagline is the phrase connecting. So I want you to say it. I know it may be odd, but I want you to say out loud because it's truth when you speak it out loud. Connecting. Connecting. So connecting means joining or linking things or people together, especially so as to provide access and communication. Access and communication. That's the core of connecting. And I like this definition of connecting from Merriam-Webster. It says to join or fasten together, usually by something intervening. All of us understand what that means. Usually you're joined or fastened together by something or someone intervening. And so this week's convening, anchored by the coming together of the 4 universities in the UM system with us, endeavors to do just this. Intervening, stepping in, and stepping up to connect people, policies, practices, and systems to address and close the health disparities gaps for those who bear the burden of disease and desperation. This is our business. I'm curious to know, so please, I want to have a generative discussion as much as Zoom and all of these technology pieces will allow. Put into the chat for me and also write down for yourself, old-fashioned, but do this, take a pen and write down for yourself. What do you envision for Missouri? Forget about everybody else. Don't think about even the institution you may work for, but what do you envision for Missouri? What is the just future that you envision for Missouri? Go ahead and bring that into the chat as you write down your own reflection. And think about this. What do we want to be the Missouri identity? Not what has it been, not what do we think it is, but what do we want to be the Missouri identity. As you're thinking and reflecting on that, I'm going to see what comes through. Here's something that I'm sharing with you that's coming through. A Missouri where your address doesn't impact your health care. Greater access to health care in all caps for everyone. What else? All things Missouri, all things Missouri. Let's think about Missouri. This is our home, right? Greater access. Okay. Healthy people, thriving communities, increased health literacy. Thank you. And continue, please, to populate the chat and be in thought with me about your answers. Well, in my version of Missouri that I envision, no one is invisible in the Missouri I envision. I envision a Missouri where all Missourians are valued equally and live as equals. And with our commitment to improve Missouri's economy, education, and health, we will know we've made strides when our children, our elderly, our Black, Indigenous, people of color, LGBTQ communities, and community members thriving beyond their disabilities tell us so. It will be based on what they tell us and what we say together. And as long as health inequities and wealth gaps and structural racism and the rural versus urban mindset exist, friends, colleagues, we have unfinished business. Can I read to you more of what you all are saying to each other? To not worry about how kids are treated regardless of race or ability. A more cooperative culture that lifts everyone up. This is the Missouri that we are working for. The panel that is coming after me, the director that came before me, the Missouri Extension. This is the Missouri that we are envisioning and we are working toward. So now that you shared and you're continuing to share what you envision for Missouri, share again with me in the chat and on your paper, okay? Because I want you to keep this. What stands in the way of the Missouri that you envision? What stands in the way of the Missouri that you envision? So to John Doolittle's response, what stands in the way of Missourians delighting in each other's successes and wellness? Funding, okay? Broadband. A sense of scarcity, mistrust. As long structural inequities. Allow me to share my reflection of what stands in the way. We have been socialized into either or thinking, rural or urban, win or lose, right or wrong. And here's a both and that connecting will dismantle, divide and conquer in order to control. Let's be honest today. Our news feeds and media outlets and narratives within our families sometimes have reinforced the need to fear one another, question each other's motives. Here we go. Withdraw and retreat into isolation. But again, the word that is admonishing us today and throughout this conference is connecting. I want you to say it again, connecting. So now I want to spend some time with you asking you 4 key questions to get your reflective juices going, because reflection is the first step in change. Self-awareness is the first step in accelerating equity. Number 1, what is your unfinished business? What is your unfinished business? Don't be the person that stands in the way of the Missouri that you envision. How well do you tap into the power and influence you have to make change happen? See, In my opinion, change happens from the inside out, and transformed people transform systems. So for us collectively to move change, it starts with us and it starts within us. So what is your unfinished business? How are you activated in this moment to tap into your leadership purpose? What injustice are you fed up with that fuels your commitment to accelerate health and education equity? Why is it that you feel passionate about? What is it that you feel passionate about that remains unfinished but is in your hands to accomplish? And as you think about all these questions, what are you afraid of? Let me ask you another question on question number 2. How well have you taken care of your spiritual, emotional, and physical well-being? Just be honest with yourself. I'm not reading your paper. But how well have you taken care of yourself? Your spiritual, emotional, physical well-being? How well has the ecosystem taken care of you? How well have systems taken care of you? So here's some thought for you. Practice courage. Ask for what you need. Practice no. That's a thing that Bethany's practicing. Not very well, but I'm still trying, right? And tend to addressing wholeness and wellness in you. Rest. I want you to put that in the chat because it's so important, and say it out loud. Rest. Practice disrupting patterns in self, systems, and services. Got the 3? Practice disrupting patterns that are unhealthy in self, systems, and services that work to advance the few to the disadvantage and disenfranchisement of the many. Build a strong foundation of networks and connections and relationships and support systems that will be required to sustain the level of lift that is ahead of us in Missouri. My third set of questions. How comfortable are you in acknowledging and leveraging your privilege and power? And if your answer in honesty that's coming through the chat, I see you, is that I'm not that comfortable with it, get comfortable with acknowledging that you have awesome responsibility, improbable privilege and power. You are a policy influencer. You are a policy influencer. You don't have to be a legislator, but you are a policy influencer. But do you see yourself this way? Right? Do you see yourself? Do you own your identity as a policy influencer? Can I tell you a secret? The secret's out. We are history shapers. We are history makers. But do you see yourself that way? See yourself that way. Your leadership, no matter your title or where you sit organizationally, are critical, and your strength has been preserved for this moment to help Missouri finish the work that is unfinished on our watch. Keep on populating in the chat. What, in your opinion, is the most critical obstacle that we face that perpetuates our state of unfinished business? In your opinion, what is the most critical obstacle that we face that perpetuates our state of unfinished business? I assert that the most critical obstacle that we face is the crisis of trust. Let that sink in. The crisis of trust. Did you hear it in the earlier video when she said that trust and relationship is so fundamentally important to the innovation? But we are in a crisis of trust. Titled as the 8th of 15 lessons in the COVID-19 pandemic, is teaching us in the March 15 AARP bulletin. If you haven't had a chance to see that, please do write that down. Our trust is in one another has frayed, but it can be slowly restored. Here's a comment coming through. Even trusting myself is an issue. I got trust issues with me. Who will listen to me? What can I possibly do? Trust at the fundamental level and belief in ourselves and our power to move change. There is a crisis of trust. But I want to quote this. Even before our views were perforated along lines dotted by pandemic, politics, race, class, and whether Bill Gates is trying to save us or track us, we were losing faith in society. In 1997, 64% of Americans put, quote, a very great or good deal of trust in the political competence of their fellow citizens. 64%, right? But today, only a third of us feel that way. A 2019 Pew survey found that the majority of Americans say most people can't be trusted. Sit with that. Most people feel that most people just can't be trusted. And that was in 2019, pre-pandemic. And it's even tougher to trust in the future. Only 13% of the we will not be silent millennial generation say America is the greatest country in the world. Only 13% of our young people believe that America is the greatest country in the world, compared with 45% of members of the silent generation. Well, no wonder that by June of last year, friends, polling showed us after the January insurrection on the Capitol that the quote, I'm proud to be an American, was the lowest than at any point in the history of taking the Gallup poll. So when trust is high, hard things become easy. But when trust is low, easy things are very hard. The greatest contribution we can make to restore faith, period, because I'm a faith person. So the greatest contributions we can do to restore faith and faith in our democracy and improve the health of the human condition, we must see ourselves as connectors and trust builders. And it's from the inside out. So if you struggle with trusting yourself, we're going to have a hard time building trust among networks and communities and institutions and each other. We must see ourselves and the power of who we are to become connectors and trust builders. And here are 6 ways that we build trust when we consider these 6 areas. Number 1, share common commitment to equity through policy, practice, and self-awareness. It is our collective responsibility to work together to ensure that Medicaid expansion, which is the will of Missourians, is implemented in a way that values the dignity and respect of each beneficiary and their family. Number 2, integrate trauma-informed approaches into the fabric of everything we do, because unmetabolized grief will be with us for at least a generation. Unmetabolized grief will be with us for at least a generation. We have to have trauma-informed approaches. Number 3, trust and amplify the voices and lived experience by putting our money where our mouth is. The business of healing and well-being are left unfinished because we don't trust. In fact, we often fear communities when they activate in their collective power. Number 4, we can handle the development and rollout of precision medicine, and how we handle that rollout is our next test to confirm if we truly value equity. The body is a system that depends on interconnectedness. So it seems to me, just my opinion, that the solution to our most pressing health problem lies more in thinking about whole human beings, giving less weight to breaking everything down into DNA sequences. There's something about divide and conquer to me in precision medicine that I'm just going to have to be persuaded about. Number 5, commit to support public health infrastructure building and sound public health practice. We know that Missouri is woefully underfunded here, and greater respect and support must be provided to our colleagues in public health. That is essential. That is a must. And number 6, lean in for this one. I can feel you. Lean in with me. We need to evaluate the new trends that are developing in workforce. Do you notice that change is afoot? I raise an eyebrow at the individuals who say, quote, all the workers are staying home to get paid. It seems to me that the working class are seizing the opportunity to control their own destiny, and influence their own health and well-being through having choice now. The choice of their work environment, the choice of wages, the choice of benefits, the choice of being valued, the choice of having many opportunities, the choice of being entrepreneurial now, the choice of saying I don't have to be subjected to living in conditions that are not working for me and my family. And as people say, where are all the workers? Where are all the workers? Has it dawned on anyone that we've lost more than 4.92 million people around the world? We've lost that many people. And more than an undercounted 12,628 deaths in Missouri. People are missing. People have died. People are not here. And the traumatic grief of loss for our children, for our grandchildren, for us, it is astounding at proportions that we have not predicted, nor felt, nor frankly prepared for. Now, however, after I've left you with all these points on being trust builders and connectors and healers, I leave you sharing that I have a sense of optimism and hope. That's why I'm in the fight. That's why I'm in St. Louis. That's why I am a Missourian, right? I have a sense of optimism and hope. I want you to say that with me. I have a sense of optimism and hope. I'm a social worker. I believe in people power. As community healers, that's us. As power brokers, that's us. As restorative justice leaders, I believe that it is our business to model now for future generations how the future that we envision and call into being is inevitable because we're here for such a time as this. system, because you're here, and the commitment to a just future. Prove to the disheartened that rebuilding trust and restoring confidence in democracy, restoring confidence in neighborhood, restoring confidence in community and in each other is possible. Now, is essential. It is essential. And so I charge us. I charge myself every day when I wake up in the morning to show up in authentic relationship. Show up, speak up, be your best rested self. Be your best rested self in authentic relationship, demonstrating what integrity and transparency and simplicity in data and methods and communication looks like in everyday practice. Let's bring it out of the research room. Let's bring it out of the classroom. Let's bring it into community. And let's show the naysayers how social change is supposed to be done to the benefit of the many, to the benefit of everyone, not just the small group. The kind of change that doesn't overly benefit one group at the expense of all others. So mark my word, the new harvest of the good seed that has been sown is just below the light of the sun. And what is coming, because we're here, is better than what has been. Now we know we got work to do, and that's why we're here. But be well and do well and remain focused in your resolve to the Missouri that you envision. And be encouraged that there is reconciliation after reckoning. But change moves at the speed of trust. So with that, I want to thank you so much for allowing me to open up the conversation, perhaps even open up your heart space, open up your head space to ready us for the discussion with our panel and for just the place that you are in your own journey in the leadership of this work. Be well. Thank you so much for having me.
And thank you, Bethany, for what wonderful challenge and some things to really reflect on. I'm looking forward to this conversation to really dig into that deeper. But there were some really key things that came out, and one of the phrases you used, and I think it really sets a tone for this next part of our program we bring in the panelists, is to think about trust, being a connector, and being a healer. Those three things really stood out, that if you're going to do the kind of work that we're talking about, which is fundamentally working with community, getting into community, partnering with community, figuring out where they are, and then bringing them alongside of where we may go and may need to go, that trust is key. Connecting is critical. And yes, that then we become a part of that healing process. You've hit on a lot of things about trust, and it's interesting. If you go back and look at this program, a couple of years ago, we had Stephen Covey here, who talked about the speed of trust. And what you just closed with was right textbook from his book about the way that you speed up trust and the way you go about that and the way you cause things to happen is to build those fundamental pieces that bring us together and help us see what our common interests are so that we move forward together in community, as a state, as a country, whatever level you may be. So what I'm going to do now is kind of pivot over, and we're going to begin to bring in some panelists and to join Bethany. She's going to stay with us. We're going to have her as a part of the panel. We're excited about that, and it's great to meet you virtually. I look forward to the opportunity, again, Bethany, for us to have a conversation where it's not looking through a screen sometime. But great job. We appreciate your really challenging and encouraging comments about where we could go and where we should be thinking about going as a state. We're also pleased today to have Christy Campbell. Christy comes to us as president of the Missouri Public Health Association. We're excited about the conversation we'll involve her in and engage with her. I'm also glad to have a colleague here at the University of Missouri, Karen Edison, the medical director for the Missouri Telehealth Network, the Show Me Echo program through the School of Medicine here. And we've worked together on a number of projects. And Karen, it's really good to have you with us today to share that perspective. We're also glad to have a colleague of hers and a colleague of mine as well, Rachel Mutrix, who's with us today, who also works with Missouri Telehealth Network and a great leader and does some really innovative things and has done a great job with other colleagues, including Karen, to really expand our reach in the time of pandemic and done some wonderful work there. We're also glad to have Melissa Van Dyne here with us, who is the Executive Director of the Missouri Rural Health Association, who will bring that perspective from the rural perspective and how some of the critical needs that we're looking at there. And then lastly, someone that I just met a couple weeks ago, John Doolittle. I was actually in Chillicothe, Missouri, speaking, and someone came up to me, and I had mentioned the Missouri Hospital Association being a partner of ours, and little did I know that in the audience was sitting the next next CEO and executive director of the Missouri Hospital Association. So John, congratulations on the new job, but also it's great to have you with our program. It didn't take long for you to get here. So we've been very pleased to work with Missouri Hospital Association, a great organization that has been partnering with us literally since I started here. I came in and immediately began to make inroads with them and learn about their structure and how we could partner. So again, we got a great panel today. We're going to get started here. We just heard Bethany give us some really good insights. We saw the video earlier. And some of the things we want to do, we're going to frame a few questions here, kind of pepper those around the panelists here to have them respond. But also we want you to know that you can send some questions in. We'll try to take some of those as well as we go forward. But the first question I'm going to pose is, what are we learning about health systems and structures in Missouri as a result of COVID? We've just come out of COVID. And maybe what are some of the things that we've learned and maybe what some things that we think long-term will maybe help us. And to get that started, I'm going to go over to Christy. And Christy, have you start off. And what are some things you're seeing that maybe we've learned out of this COVID experience that might be informing to us as we go forward? So Christy?
Good morning, and thank you. Yes, I think the biggest thing that we have learned is that we have to rely on our partners, and we have to expand that network of partners to think about groups that we have never worked with before. We all have our strengths and weaknesses, and we need other partners to help fulfill the needs and fill in those gaps that we saw in our process. We, as a Missouri public health system, worked with hand in hand with the hospitals, with the federally qualified health centers, but we also reached out to groups that we have maybe not worked with before, definitely the churches, the Lions clubs, the cosmopolitan clubs, those other clubs and organizations where we could reach those hard to reach populations and the underserved and get our services out to everyone that needed them at this time. So partnerships were definitely big, and expanding the ones that we didn't know that we needed at the time.
Well,
Thank you.
great comments. And Karen, I'm going to pivot that same question to you. And I know you and Rachel work a lot together, but Karen, give us some thoughts about what maybe you have learned or what you've seen happen from your perspective of working with telehealth and the ECHO program here at the University of Missouri.
Well, as you know, we started several echoes around COVID. And one of the things I learned, we have a public health COVID echo every Monday at noon. And on that expert hub team, we have critical care doctors and infectious disease doctors and respiratory therapists and all these people from all over the state. And I have watched them come together collectively and become a community and learn from each other and teach each other, quite frankly. We also, in the real heat of the pandemic, had an echo around critical care kinds of things. And we had a longstanding one around nursing home issues and then one around COVID and kids. And I saw so many wonderful opportunities for doctors to learn from other folks on the healthcare team. I'll give you one example. Back in the heat of the pandemic, proning or turning patients on their stomach was thought to be an evidence-based way to expand their lung volume. And there was a head nurse on a COVID unit, and somebody asked the question, what does it mean to prone a patient who's, intubated and has central lines and tubes and all this stuff? And she just very earnestly talked through what that meant. And I watched the critical care doctors and I watched all these people's mouths drop, because it takes like 7 people in an hour to turn somebody over in that situation safely. And the doctors didn't seem to have a clue. They just give the order and go on to the next thing, and they were all, their mouths were just dropping. And that's just one little example of the kind of sharing and understanding that has occurred during the pandemic. And also we have folks from WashU and the VA and Kansas City and St. Luke's and Springfield and Cox and MU, and it just, all these people now feel like a community. And I think that's been kind of an amazing thing to see.
So we've heard about community and where Karen has really taken us. And then earlier Christy talked about the partnership piece. Rachel, what have you seen in this space coming as we've gone through a pandemic? What changes or maybe some adjustments you've seen in the health system from your perspective?
Thank you. I think when I think about, I'm going to keep it on telemedicine because I've been working in telemedicine for about 20 years now. And what happened during the pandemic was something that we had hoped would happen, 15 years ago, which was the ability for our healthcare providers to take healthcare right into the home by using video conferencing technology. So because of the public health emergency order, payers are now paying for healthcare providers to see their patients at home. And I just want you to think about, in the old days, and this was before, probably before any of us were born, when it was common for healthcare providers to go to the home and do house calls. And when they did that, they would often be able to see much more about the patient and maybe more about what was keeping a patient ill than when the provider or when the patient came to them. So when a patient comes into your healthcare office and they present to you, you don't get to really understand what's happening in their home. But even through telemedicine, if you go into their home, oftentimes you can really understand different things about that patient and help them heal in ways that you couldn't when they are coming to you. And so that's the biggest change that I see. And fingers crossed on the federal side that we can keep that change in place after the public health emergency order ends.
Yeah. Well, again, that's a structural change. You're seeing providers pay for things maybe they used to not to. You said it very well that it was a goal of telemedicine, telehealth, to really have more people getting into that sort of that stream of way of thinking. And we saw people rush into that. And I know in talking with folks at MU Healthcare, to see that continue, it's been sustained. And again, it'll be interesting to see what happens after the health order changes at some point. But again, to see people now adopting new technologies and new ways of going about receiving health care has been a phenomenal thing, and it allowed people to stay in place and get care. So again, great points here. Melissa, I know you look at it from a rural perspective, definitely. I'm sure other perspectives too. But are you seeing some unique things in the rural space?
Right. Well, like Rachel had mentioned, telehealth definitely exploded in our rural areas. And again, yes, we were hoping it would have exploded 15 years ago. But this definitely gave us the opportunity to really take a look at telehealth and how to implement telehealth in our rural areas, both at the hospital level, the clinic level, and in the waivers and all those things did help, and we hope that it continues to do so. What I really did also see quite a lot of, and I've worked in rural for 10 years, is, and I've always thought our rural providers and those working in our rural areas are the most strongest, most resilient people I've ever met. And that really came out during COVID. And I have never witnessed in my 20 plus years in public health that kind of resiliency in our rural communities, and really looking at innovative ways to get to their communities, get people tested, get people treated, and get them where they needed to go. And I really think it kind of came back to what Bethany was talking about earlier, and that really connecting with one another and keeping those lines of communication open and sharing that common commitment to their communities. So we definitely saw a lot of that, and what Bethany was talking about when she was talking about it really hit home for me from what I was seeing on my end. And I know John can probably talk firsthand about that, having been in the rural community during that time.
Well, thank you. It's great insights, and I would agree that we've seen so much resiliency. I know you were talking about people connecting, and we heard stories, and we know for a fact that just seeing people once again call, say, on elderly who felt they needed to stay home because of the pandemic, they were quarantined or just not wanting to get out, and having, I know in our case, extension colleagues went out and bought groceries and brought them to the door and left them on the doorstep. We saw some incredible reconnect with community that I think is really important. And again, it's sad you had to go through a pandemic to get there. But again, you look at what did we learn and what do we need to hold on to as we go forward. Now, John, I know you're new in the job and don't want to put too much pressure on you, but you have been in this business a long time, and would love to have your perspectives as well as you think about the healthcare systems and also in your new role. The lessons learned, things that we might have picked up on as we've gone through this process.
Well, I think what we've talked about here is an incredible testimony to the power of vision and faith. I am on day 3 at the Missouri Hospital Association, but for the last 11 years, I've been at my hometown hospital. And soon after I arrived there, my step-grandmother needed a dermatology appointment. Now, how am I going to find a dermatologist in Albany, Missouri? Well, we were already connected to the Missouri Telehealth Network, and actually she saw Dr. Edison and had a wonderful outcome. The rest of the healthcare environment may not have been ready yet for wide-scale deployment of telehealth, but there's a reason we were ready when the pandemic hit, and it was because people had vision about the way things should be, and they had faith to continue to pursue that, and enough organizational support, to really make it happen well. And so, again, most of these things don't happen by accident. And I think one of the things that we've learned is that it's a tough thing to operate, any number of our institutions, including rural hospitals or hospitals in general. Profit margins are thin. We're asked to do amazing things. And sometimes there is a little bit of fear, a little bit of scarcity thinking that comes with that. To the extent that we can also make sure that we're providing adequate resources for people to plan for the future and be ready when the next thing hits. there's obvious goodness in that. And we just saw such a powerful example of how that can work. Really the other thing I would say about this is back to this theme of connectedness. And we had worked in collaboration with the local public health agency up in Northwest Missouri for a long time. We liked each other. We got along well. We forwarded invitations to each other's things. But it wasn't until really this year it was time to start figuring out how we were going to deploy COVID vaccines that I picked up the phone, called the new director of Tri-County Public Health and said, hey, I'm not sure if you're doing this or we're doing this, but I know that we're doing this, and whatever we can do to help, we want to do. And it has been an extraordinary success story that not only has helped our community, but it's helped us all be really proud of who we are and what we do. The fact that we engaged in a new way and really delivered incredible success across lines that previously had maybe been a little darker. We got out the eraser, we erased organizational lines, and we did the work, and it was beautiful.
John, you bring up a great point. And Bethany, I want to go back to you because I think you've just heard a great array of ideas. And as an influencer, someone that's definitely has a great influence in this space of health disparities, et cetera, health inequities, et cetera. Bethany, from what you've heard and then also what you've seen, any takeaways of good things that maybe have come out of the pandemic as related to health? Any perspectives or insights you might share?
I would just say that my learning and my experience also as a caregiver of seniors during all of this is the multiple epidemics and pandemics that came together. So I know in places where there are multiple identities, we had to use words like dual pandemics. We had to talk about structures and systems that weren't working for people prior to pandemic. It was difficult at times and still is the challenge because of lack of trust that something as simple as saying, please wear a mask because of this benefit, or whatever. There's a lot of mistrust and information. And so figuring out ways with which to invest in and support trusted people and communicators and to have systems pivot was something that I learned. And the top thing that we actually were so grateful to have in place was the structure of community health workers. Mm-hmm. Not only to have community health workers, but to begin to think about how we invest in infrastructure that allows for more community health worker leaders to organize in ways that can really promote healing on an ongoing generational basis and not just for a crisis.
Yeah, and again, seeing those systems work across, finding out where our weak spots were, identifying those, and now seeing how we pivot and then continue this good work is important. I want to go back to our panelists again. We're going to go through another series here to kind of talk about it from a different perspective. What are the new opportunities for improving health outcomes? What do you see as here's an area we ought to seize on or we ought to think about? And what we'll do is we'll go right just back around the network here, folks. Christy, any new areas you see that we can work in terms of health outcomes?
I'm hopeful that this new focus on health will cause people to think about kind of their whole self of health, sort of how Bethany, talks about, we really learned that your chronic health conditions or underlying health conditions impact the way that your body responds to the introduction of viruses and other things that were encountered during the pandemic. We know that unfortunately childhood obesity increased during the pandemic, and obesity is one of the underlying health conditions that can contribute to some more severe illness with COVID-19. So I'm hopeful that we brought this underlying health condition issue to the forefront and people will start to take a more healthier approach to their entire lifestyle with eating right and taking their vitamins and boosting their immune system and exercising and getting those cancer screenings and other screenings for health conditions that seem to take the back seat during the pandemic, unfortunately, really need to come to the forefront now. And we need to work on getting our whole population healthier so we can have less chronic disease, less incidence of communicable disease, and be a healthier workforce and keep those kids in school so they can be healthy and learn what they need to learn. So I'm hopeful for a refocus on healthier lifestyles.
Christy, as I hear you talk, I was thinking about what I heard Francis Collins talk about, director of NIH yesterday, And he was talking about the same kind of themes, that we've got to get on the front end of this and help people make smarter decisions on the front end, so that when things do happen, and they will happen, that the effect is not as great. So really good insight, and something that I think we now have the attention of the public on, that we ought to seize. So again, I'll go back to Karen Edison. Karen, thoughts on outcomes and maybe some things we learned during this time that could be very helpful to us going forward.
I mean, I think many of you know I'm very passionate about our Show Me Echo program, and I really feel like trust is at the key. That's what entering into a learning collaborative through telementoring, that's what we're creating, are these communities of trust. And so whether it's on diabetes or suicide prevention or HIV or whatever the topic is, we're creating communities of trust so that quality healthcare outcomes, evidence-based medicine, and best practices can be shared widely. Also, the O in ECHO is outcomes, and we're really interested in if ECHO can have an impact on the rural workforce retention and satisfaction. And so that's one of the things we're really looking at, because one of the things about practicing in a rural area, people will always tell you, is they feel disconnected and they don't feel supported. But through our ECHO program, we can really support our rural healthcare providers. And I'm going back around now and talking to all of the federally qualified health centers, and they love ECHO. At the end of my talk, I always ask if anybody has anything to say, and I'll always have people witnessing about the impact that has had on their lives. And, there's a nurse practitioner in Eminence, Missouri, for example, who has personally diagnosed and cured over 100 Missourians of hepatitis C through her work with the hepatitis C ECHO. I mean, there are pediatricians all over the state who are now deemed worthy to diagnose autism early. And that's important because the Missouri Medicaid program, MoHealthNet, will pay for early therapies needed. And it matters because our 6 autism centers in the state have long waits to get in, sometimes a year for families. And so if now MoHealthNet will say you are worthy to make that diagnosis and we will pay for those therapies. So ECHO's changing policy. We know that the ECHO participants who participate with our asthma ECHOs, their patients have lower rates of hospitalizations and ED visits. And so, we're saving money, we're saving lives. Before I retired from my clinical practice, I led the dermatology ECHO for nearly 5 years. And I know that hundreds and hundreds of early melanomas have been detected by our participants because we taught them how to screen for melanoma. And I gave some calls to action for this conference. And one of them was, if you know a man age 50 and older, especially somebody who lives alone, somebody needs to look at his back, the back of his neck, and the back of his ears, because those are our Missourians who are dying from undiagnosed or late diagnosed melanomas. So I put other things in my call to action, like, talk to your friends and neighbors who may be eligible for Medicaid, because we need more people to be aware that there is that opportunity. And that's a big policy lever. We do lots of things to help in our communities, but we need to be thinking collaboratively about big policy levers we can pull. And that is a big one. So even though Medicaid is not always a good payer for healthcare providers, it is something, and it can be a real support for our rural hospitals, John, that, we've lost so many in the last few years, and hopefully it can help shore up those facilities. So let's all think about the big levers we can pull that can increase healthcare outcomes for our patients. And Show Me ECHO is one of those.
So, when I think about what you're talking about there, Karen, I think about it this way, that obviously the pandemic and other things in society bring things to the surface, and that creates an opportunity to share, just communicate better with folks. Then the second piece of that is, what do you do with that? Well, that becomes a policy opportunity for us to think about those levers. And then finally, it's that care piece that in the health profession, in my space, we would be educators, but in your space, really talking about care and how do we bring that care through the ECHO program, which is basically, for those who may not be as familiar, it's where you bring together expertise of the university, where they're concentrated, and then they're mentoring and guiding people in the local communities through these processes to cause early screenings to occur, to help doctors make better decisions at the local level in areas perhaps that they're not as well versed in. So it's leveraging the university, in this case, healthcare system, and other partners to really make a difference in that local community. So again, I want to go to Rachel. Rachel, you've obviously have a lot of network. I know you were able to do some incredible things with the university during COVID with some of the dollars that came into the state and other things. But as you think about health outcomes, any insights or things you would share with us thinking about those things?
Yes, thank you. I think that when we talk about telemedicine again and our ability to take care of patients during the pandemic, we had to think about how to get care to them because doctors' offices were not allowing patients to come in. One of the projects that we worked on that you briefly mentioned was, we called it Hotspots for Health. And we were able to utilize federal dollars that were coming into the state to get not more than 9,000 hotspots out to patients and clients and healthcare providers that work in federally qualified health centers and community mental health centers. And at the peak of the utilization of those, which was in June, they were having, just with those devices out there, about 8,000 telehealth visits per month. And that tells you how many people didn't have access to affordable broadband. And that's just really a tip of the iceberg. So I think a huge opportunity for us right now is to think about how broadband should be viewed as a utility. And every person should have access to it, not only for healthcare, but for education and being able to be connected with their family and friends also. And I think that when you think about what would be different if everybody had access to broadband, well, a lot of things could be different. One of the telehealth interventions, I guess, that we've talked about for a long time in our field, and we don't see happening very often, is called remote patient monitoring. And if you have a patient that wants to age in place and live at home, but they have multiple chronic conditions, then there are devices that you could put in those homes to allow them to stay healthy, and especially in partnership with programs like community health workers. You have the technology, you have the people, you have to have broadband to make these projects work. But the outcomes that have been shown in projects like this, when they're funded, are incredible. People get to live longer, they get to live at home, they stay out of the hospital. And that, Marshall, that's really where I see opportunities happening is, okay, because of the pandemic, we got to try all these things. We know they work. We got to try them on a bigger scale than we had before, and we know they work. Let's figure out ways to implement them for everyone that needs them.
You know, one of the things, Rachel, this will be an interesting add-on to your comment. We had extension offices in rural parts of the state where people wanted to sign up for the vaccine, but they didn't have internet access, didn't have broadband access, didn't have a computer. So we had several of our extension offices that I'm familiar with that literally put out the word, come to our office, we will set up a computer for you, we will have someone there to help you, guide you through that so you can register. And it really made a stark impression when I had one of our specialists, several of our specialists actually sharing that really shows you the dire need for broadband. It's not a luxury, it is something, and it so much became apparent when we were going through this pandemic, that if you were not connected, you couldn't even sign up to get in place to go to get your vaccine if you wanted to. And there's so much information there ready where you can do things, but if you're not connected, you don't have that opportunity. So again, I think it brings back to, again, an issue we've been working on in our space now for several years. It goes back to 2 years ago, we highlighted broadband, and we have seen a lot of growth in that. but we've got a long ways to go. And the pandemic, again, brought that up to the surface as being so important. So I'm going to go to Melissa now. Melissa, again, looking at it again from the Missouri rural perspective, rural health association perspective, any outcomes, any things that you saw really become apparent as we come through this pandemic that maybe begin to make changes in how we go about work, or you may go about work?
Yes, I mean, Rachel's already mentioned definitely our broadband issues and how it relates to both telehealth and in-home monitoring. But one of the things that people will hear me harp on quite a lot is the transportation in our rural areas, or the lack thereof. And COVID definitely brought that, I think, to light. I've been preaching for years now that, if we can't get people to our healthcare appointments, those outcomes could be devastating. And COVID definitely shown that quite drastically in some of our rural areas. We heard stories of people not being able to get in to get tested or get in to get their vaccine just because they did not have a way to get there. COVID did a great job with mass testing events and mass vaccination clinics. So that might be some in our use of our mobile units from some of our federally qualified health centers. So, that might be a way in the future if we can't get people to healthcare in order for them to access the healthcare that they need, then we need to be able to figure out how to take the healthcare to them. So either that be that through telehealth or mobile units, or, figuring out in our rural communities what vehicles we can use to get people to their healthcare appointments, whether that be, partnering with our local community agencies there, our EMS, any way that we can get them to the healthcare. It will, I think, really improve it's been proven that it will improve our health outcomes, especially in our rural areas where they may not have public transportation or Ubers or Lyfts or taxis. So I definitely think that is something that we need to really start paying attention to. It's great if we can get health access in our rural communities, but if a person can't get out of their home to access it, then we still are not there yet.
Melissa, as I think about you talking there, I think about the work that here at the university of what we've been involved in now. If you go back to 1914, when Extension was born in this country, it was about taking the university to the people. That we knew that of this today, if you use the number today, 6.2 million Missourians, they're not all going to come here to get information, knowledge, whatever. So it became this idea, this Extension idea of moving it to community, putting it in their hands, taking it to the farm, taking it to the business, taking it to wherever they are. And it's really, I think, what we're finding is a return to that idea in a new way, because now we have technologies, we have other ways to get to them, but sometimes those technologies still are not quite there. So we've got to figure that out. So it's really a call to action for all of us to realize that we are our brother and sister's keeper, and we need to figure that out. It's, for those that are connected, not so you don't think about it every day, but those that are not connected, those of us that are, we need to be thinking about them, need to be figuring this out to help others have the same access and the same information and the same kinds of services that are so important for health, in particular, as we think about this issue. John, again, you've heard the conversation so far. As you think about maybe even going forward with the Missouri Hospital Association, you see things they're going to be doing, or maybe drawing from your past in Northwest Missouri, so maybe some experiences there of things that you think are now going to be different. I know earlier you talked about how we kind of did away with all the silos. We said we got to get the work done. I thought that was really insightful in the earlier question. But give me some sense of that. What are you seeing, or things that maybe you think could be happening as we go forward in this whole health arena?
Yeah, Marshall, I think it fits well with what you were saying. And actually, a couple of weeks ago when I met you mentioned the Hospital Association as a partner with the university and with Extension. And we were talking about data. We worked closely together, organizations, on exploremohealth.com and giving people information about what's really going on. Right? We all have a gut feel or a sense. And thank goodness we don't always wait for perfect information to go take action. One of the things that we've seen is over the last 2 years, people have had a sense of their neighbor's need and they've taken care of it. We used to have a guy named Chris. Chris would come to our hospital every evening at 5 o'clock to get an evening meal because he didn't like to cook and he knew he needed to eat better. And what we were serving at the hospital was healthier than what he was going to get at the convenience store. Well, then we had to close our cafeteria to the public with infection prevention considerations. And literally, my assistant, Jill, realized that Chris wasn't going to get a good meal and just started gathering every day at the end of her shift, or sometimes not the end of her shift. She'd go and come back, I guess. She started taking a meal to Chris every day. And pretty soon, that became something that we were thinking about more broadly. How are we going to get healthy food out of this hospital to people? There was no study, there was no dashboard that pointed us the need for that. It was just people thinking. But at a larger level, and when we start to think about things systemically and programmatically, Explore Mo Health is a great resource. It's something that we're going to continue to enhance, put information in the hands of entrepreneurial thinkers who can go do great things. And then you probably saw at the beginning of last week, Kansas City Star picked this up, some others have talked about it. We have these wonderful new health equity dashboards, right? So we're taking information that had been available at the county level about what's really going on and how we can pinpoint needs and begin to have very specific and targeted action plans to address health equity disparities. We've got that all the way down at the zip code level now. And we are able to put information in folks' hands. You can get to this through the Missouri Hospital Association website, and really drive down at the county level and then the zip code level, what sorts of things are we seeing? And so equipping folks in that way has become a strategic priority for us. I had the great luxury of being the CEO of my hometown hospital for the last 11 years. And you wonder, why'd you leave? There are 120 acute care hospitals belong to Missouri Hospital Association, 142 total members. And over the last 3 years under Herb Kuhn's leadership, I'm going to read this so I don't mess it up. Our strategic plan mentioned a transition from, quote, providing services for hospitals and health systems to, quote, a system that supports the delivery of health, right? We're doing our part. Missouri needs strong hospitals. There's no question. There have been a lot of thinkers over the last few years who I think appropriately have realized that the American healthcare system is expensive. It's inadequate without really strong public health. It's not that hospitals and health systems are the answer to every problem. But what we have seen in the last 2 years is that when there is a real need, a real acute need in the community, hospitals are part of the answer. And we see it every day. So we develop these partnerships. As I was wrapping up last week in Albany, we had a mom and dad walk into the hospital with concerns about their 18-year-old son, possible harm to self, possible harm to them, possible harm to their family. They didn't go to the local police department. They came to the hospital. They walked to the emergency department, and they knew that somebody there was going to care and that we were going to help them solve this problem. And so whether it's at that really micro level, and we're thinking about how to be strong at the front end from a health delivery system standpoint, whether we're partnering with folks to figure out how to get those parents last week the information they needed, the help they needed for their son, or whether it's collectively pulling together all of this wealth of information we have and making it available to entrepreneurial problem solvers around the state, working in partnership with the university. This level of system thinking, it portends a really great decade and decades ahead. And honestly, that's why I'm here.
Yeah, it's, John, I'm really glad you are there, and obviously had the great opportunity to work with Herb Kuhn, your predecessor, and the work you're doing and moving from just being a service to the hospitals and supporting them to really being an integrated part of the solution is what I heard you talk about there in your answer. And I'm really excited about what I hear there. And one of the things that I would share with our viewers is, just so they know, we have partnered with Missouri Hospital Association and others that one of the things he talked about was this zip code health indicators. Those are actually done here at the University of Missouri. One of our groups here that works under MU Extension actually works with that with some national partners pulls a lot of that data together, and it's used throughout the country. They actually do it for the whole U.S., and then that's integrated into these different websites. If you go to allthingsmissouri.org, one line, allthingsmissouri.org, you'll find that data there to look at health indicators, education, economy, all kinds of things. So I just, again, what John's talking about is this idea of pulling together, of figuring out. I love the illustration about the guy who was coming to the hospital to get food, and then he couldn't, and so someone says, "There aren't any rules about this, but we're going to make sure he gets fed." I'm all about that, and I think certainly our viewers are, that it's about doing the right thing because it's the right thing to do. So, Bethany, again, you've heard a lot of things here. Reflections or thoughts maybe that you have now listening to this great panel of experts we have with us today.
Well, I want to reinforce, first of all, how much it resonated. I think when Melissa was talking about transit and transportation, yep. It is the same for us as well. It's because you have a more aggregate core. Transportation became a little bit difficult and challenging. So transit, I think, really is a Missouri issue that we need to continue to look at. I appreciate out of crisis this one thing that it feels to me like the stigma of mental health began to release itself. And so the emphasis on well-being, on focusing on detoxing from stress is really important. Now, I would offer that what I didn't hear, but it is part of on my third day of my job, like John, is thinking about health as civic engagement, that a healthy, informed population who understand their rights, that understand what is moving, that politics is not something lofty and heavy and once every 4 years, but truly is policy that we are shaping and moving at the granular neighborhood level should be considered part of health and a priority, that we have a strong and informed electorate in Missouri. So I would add that to it. Grateful to hear about the dashboard. There's several dashboards out there, but didn't know to go to these 2 sites. So the first thing I'm doing when I get back to my office, I'm going to look at those, because I think truly we have access to information, perhaps an abundance of access, but how to tap it, to use it for effective, like rooted on the ground way is something that I'm thinking about. And lastly, I would just add to all of us that trust means keeping our word. So my dad, who's a preacher, right, said, if a man's no good, if a man's word is no good, he's no good. And so this notion of, if we make a commitment to community, if we are in partnership and relationship, we have to deliver on our promise. And if we don't, we have to be accountable to say, I messed up, I didn't know, my bad, but we have to fix that. So those are all the things coming up. Grateful for the fact that this 20% medical that we've always focused on, we are opening up now to think about the other 80% of what affects population health.
Yeah, it's very insightful. And again, I think you make a great point in that, there's so much data, so much information, but those of us who sit in those seats of influence need to use that data to make better decisions. And if you don't use the data to make better decisions, you really haven't gained anything by having the data. So again, lots of opportunities there for us to collaborate and to think about new ways of doing things to scale, so that, again, Missourians are better served and therefore healthier in their lives. We're going to make another round here. I know we've got a couple questions that have come in. I'm going to try to get to those too, but did have one last question from our perspective. And Christy, I'll start with you again. We hear a lot about this issue of health equity, and means, again, depends on your view, what you see there and how you may see it coming about. But when you think about health and well-being outcomes and health equity, any insights or thoughts you see, or maybe things emerging from the space you work in?
I think as we work together to increase those partnerships and to fill the gaps, we will help to address some of the health equity needs as telehealth, as more transportation, as we look at population health, as increasing access to places to exercise like parks and healthier food options. So all the work that we are doing is building towards improving population health, increasing access to hospitals, getting those satellite clinics, or just telehealth. Whatever improvements we're making, it's all towards that goal of health equity and making sure that every person has access to the services they need. I might need the same services as my neighbor. So, that's not equal. It's what's I need, what every person needs for their health. and we want to make sure that they have access to that. It's easy, it's affordable, and it's the right choice for them.
You know, Christy, yesterday we opened a next-gen precision health building here, complex. A lot of work around that, a lot of communications, outreach about that yesterday. And one of the things that was talked about in some of those, some part of that ceremony was personalized medicine and personalized health and making it very personal. And what you're talking about there is our care, our concern needs to be unique because every person is different. Everybody has something different. So our ability to partner in ways that, again, keeps the individual as our focus. That it's about them. It's not about us. It's about what do they need. How can we partner with them to help have better outcomes? So, Karen, I'm going to go back to you. Thinking about health equities, thoughts you may have.
Well, I have a lot of thoughts about that, but I'll try to keep it brief. First of all, I'll say, and Bethany mentioned this in her talk, I think the issues around health equity and inclusion and diversity are a leadership issue. And I think all of us as leaders, and we're all leaders in our own right, we have to do that internal work first. We have to look at ourselves and our own internal biases. And because if you don't understand, we all have biases. And if you don't understand yours and your history and where you came from and what you bring to this world, if you don't take that hard look at yourself, it's hard to be able to work through them to do the best for all people. Let me just say that. I also want to say that, I hope that Missourians are beginning to realize that healthcare is not about doctors and hospitals and nurses. Healthcare is about where we live, learn, work, worship, and play. And healthcare also is best if it can be delivered regionally, if not locally, because local healthcare providers know about the culture, the infrastructure, the healthcare resources available to people in their own communities. And that's why we are so invested in this ECHO model, Extension for Community Healthcare Outcomes. And if you don't know about ECHO, go to showmeecho.org and you can learn all about it and all the things we're doing in forming these collaboratives. And when we do this, when we form our expert hub teams, it's not just all from our universities, it's also from other health systems and other communities. In fact, we have over 200 expert hub team members from over 50 organizations on these expert hub teams. And when we choose the hub teams, we lead with the notions of inclusion and diversity and equity in mind. And we try to form these hub teams to reflect the patients that are being served by the providers that are participating in that learning collaborative. So whether it's, child psychiatry or rural veterans behavioral health or suicide prevention, whatever the ECHO is, we try to choose people on that hub team that can represent those populations. And we also are experimenting more and more all the time with having people on our hub teams that have lived experience. So on our Autism Hub Team, we have a parent of an autistic child, for example, and we're seeing it's important to have people with lived experience on those topics.
Wonderful, wonderful comments there. And again, I want to just compliment you, Karen, on the great work that I know the ECHO program does, has done, is doing, will do. It continues to grow and expand and is allowing, it's a tool that we're using, quite frankly, to address inequities. I mean, it is, because it's bringing equity to a space that we need it in terms of care. So again, Rachel, I'm going to go to you. Thoughts on equity and maybe some insights you may have from your perspective of telehealth.
Well, Karen took a lot of what I was exactly thinking in my head because we work together so frequently that we often talk about the same things. But I was on a call yesterday that had to do with telemedicine and health equity, and the thought was that you have to be intentional because oftentimes these projects that we think are going to provide greater access, they really highlight the inequities in the communities. So going back to broadband for 1 second, if you think about, yes, we transitioned to telemedicine really quickly during the pandemic. However, it was only for people who had broadband services, right? And so you saw the gulf, the digital divide, so to speak, get bigger. And so I think the intentionality and having people like us helping to think through ways to allow the leadership at the state to understand that broadband needs to be a public utility, and everyone needs access to it. Otherwise, all these great programs we have, while they do good, they're not going to do good for everyone. And so I think being very intentional in the way that we think about moving forward with these projects is probably the best thing we can do.
I know, Melissa, I was thinking from a rural perspective about my own work and where I travel. I've been, I think, now in 111, 114 counties, and most of those were in my first year here, and I've been going back ever since. And when I think about the inequities and the things that I saw in just traveling, I saw what I would refer to as healthcare deserts in some areas. They'd lost their hospital. There was no primary care physician. As you folks think about that from again, the Missouri Rural Health Association, where do you see that going? Do you see some areas that are maybe improving, or some things that you might share that folks listening in or watching today may be interested in on the equity issue?
Right, and you're correct. We do actually have some counties in this state that don't have any primary care physicians at all. And there's a lot of really good work being done to help increase that workforce. I know the University of Missouri, through their Rural Track Pipeline program, is doing some fantastic things in trying to skill up those that are wanting to practice in our rural areas. And they are doing a great job in being able to do that. When it comes to health equity, I always say, if you've seen one rural community, you have seen one rural community. And I really think that this is, I have a pretty simple answer. It sounds so simple. I think we need to stop hearing and start actively listening. So we need to start actually getting into those communities, really actively listening to what their needs are, and then deliver it. And I know that sounds really simple, but somehow we make it so complicated with all of the different silos and funding streams and reimbursements, and we get so tied up in all of that. It is such a simple answer, and we can figure out how to do it. We really can, but we've got to get into those communities. We've got to listen to what those needs are, and then respond to those needs. And it might be 114 different answers, and that's fine. But we've got to get there, and we've got to be able to do that for them.
Melissa, there's two things that come to mind as you're talking there. One is you were talking about all the rules and the regulations that get in the way. And one of the things that I saw happen real time here at the university level was not in the healthcare space, but it was an enormous shift. Was when we had to go to a virtual environment at the university. And we were talking about 10 to 12,000 courses that literally shifted in like 72 hours. It moved that fast. They went into a virtual mode. We actually last year had the provost with us, Lauda Ramshad was with us. She said it would have taken 5 years to do that because of all the rules, regulations, committees, and all the other things. And in the meantime, people aren't getting delivery. So I think it's a really good example. And two things of this innovation piece and how we need to move with speed and to move to action. The other thing that I think about, in particular in your space, you mentioned the partnership that University of Missouri University of Missouri College of Medicine has here with Cox Health down in Southwest Missouri, Springfield area, the rural track, which allows students to go there and have that rural experience and be exposed in that area with the hope that they will stay and choose to be in rural areas. I also will tell you that UMKC has taken that lead. They've just done the same thing with Mosaic Healthcare up in St. Joe. And in fact, yesterday I was with Molly Agrawal, the chancellor at UMKC, actually talking about this some as a part of the Next Gen opening, and very excited, seeing new funding streams coming in, a lot of excitement around that. And so I think it's an important takeaway that we're seeing the university in this space do what they can do, which is to create an environment where more healthcare opportunities will be there, and more of our trained physicians can possibly go into these rural areas. So again, in your space, I know that's really important, and I think it's important, though, that people out there know that these are things that are real time, that are happening today, that are actually moving the needle, beginning to move the needle in that space. Actually, the one in St. Joe's is going to be a full-blown College of Medicine, if you will, satellite version in the St. Joe area there with Mosaic. So pretty exciting stuff happening there. So I think over time we're going to see some change in this in a good way, but again, it's going to take time. So John, I'll go to you next and talk a little bit more about this equity issue. I know you've seen it on the ground, hospital administrator over a decade there in Albany. I know where Albany is, by the way, as you know. Been there and seen that. Give me a sense of what you see from that perspective, and then also where you sit today.
Sure. So I'll steal one of your lines first. You talked about, when you came to the state of Missouri from North Carolina, this campaign to listen, learn, and lead. And I was thinking about that as Melissa was just talking. Those are not things that are done sequentially, right? Listen, learn, and lead is a perpetual, cyclical thing. We're all leaders because we're all influencers. We've been telling those stories on this call for the last hour and a half. The opportunity for people just to activate and do things. And as Melissa said, continue to really listen, really learn and understand. So that stuff's great. As I think about health equity, by definition, this is something that's comparative. And we've talked a little bit about a sense of scarcity and things like that. And these are not either ors, right? These are both and issues in most cases. When we look at comparisons, even globally, to what's going on in the U.S., I just saw an email, National Quality Forum. I'm going to look at my paper again so I don't mess this up. Put out latest study on maternal and fetal health, and particularly around maternal morbidity and mortality. And the United States, most recent year where we have numbers, about 17.4 maternal deaths per 100,000. That is 2 to 10 times other industrialized countries. If you then look one level deeper and you look at non-Hispanic Black women, that rate rises from 17.4 to 37.3 maternal deaths per 100,000. Orders of magnitude greater than it needs to be, than it should be. And this level of comparative curiosity, followed by the freedom and ability to go out and figure out solutions, be entrepreneurial, be creative. It's really great that we're seeing this information and that we have this shared commitment to making things better. It's because we get these perhaps self-imposed mandates to go do the right thing, and when we have love and concern, and we match that with a little bit of hustle and a little bit of activism, we can do amazing things. One of the things that concerns us right now, coming out of COVID, is how much preventive care was deferred and has been deferred, right? And in all cases here, we're thinking about ways to get ahead of what otherwise would be done less efficiently and probably less effectively in some ways if you get all the way to the healthcare system. The team here has studied, COVID-19 and delayed care. We looked at cancer screenings kind of writ large, and we think as many as 90,000 Missourians deferred evidence-based cancer screenings. Guys, if we don't hustle and catch up on that, if we don't figure out how to get those people screened, as Dr. Edison mentioned earlier, for skin cancer, all these other ways, our best science says that's going to be an extra 10,000 cancer-related deaths in this state by 2030. Can't have it. And we've got time to do better. But we have had real cost of what we've done. There were rarely perfect answers in regard to the COVID response. Things changed over time, and we made trade-offs. I think we've done brilliantly in the state. I'm so proud of our hospitals and those workers. I'm proud of our public health. I'm proud of everybody that's pulled together in the state to try to minimize this. But there are real impacts, and it's time for us to have this other regarding, loving mindset and figure out how we're going to hustle to make things better, or there is a wave of second order effects coming from COVID we simply have to avoid.
John, that's something I had not heard until today about the number of how far we are behind on cancer screenings alone. Just 90,000 is what I heard you say, and what that would mean in terms of the death toll in a few years if we don't get in front of that. But I do know, I know from personal experience having people say, well, I was going to go get this checked, but I put it off because it's just too much going on, it's too chaotic, whatever. And I really think that's something we're going to have to really be educational about in our space. I mean, you've just challenged me. What can we do to make sure that our folks on the ground are making good, communicating that, so that, because they have stakeholders all over the state. So that's something I think that really comes out, and if we don't deal with that, we're going to have a whole other series of equity issues that will continue to compound. So I'm going to go back to Bethany again. Bethany, you've heard some really interesting conversations here on equity, and I know you work in this space a lot. I'd love to hear your perspectives on it. What do you see either now or on the horizon as we go forward?
So I thank you. I want to recenter us in what is health equity? What is it? Well, racial equity is essential to overall equity. And so when we think about equity in practice, it's looking at those that have been invisible, who are bearing the burden of disease and the brunt of what the trauma medically, physically, emotionally is. And we are prioritizing them, right, to be able to support because of targeted universalism. If you target a particular group that is in need in particular, it has cascading ripple effects positively broader than just that identified demographic. So with that, I reinforce that if there's one health equity measure or indicator that I would recommend that it might support what John is also saying is look at how moms and babies are doing in the state, and look at how moms of color, Black moms in particular, are doing in the state. And that is a litmus test to let us know if this ecosystem and all this work that we're doing truly is working. Number two, I can't say enough that, again, reinforcing what we've already heard, primary care now and in the future, that we need help. We need pipeline and support, not only in primary care, however, because people are quitting. They have walked off of jobs. Those that are in the medical field, not just physicians, but other supports, are tired, they are burnt out, and they are not with us. So how are we thinking about environments that we are creating for the next generation that wants to come to say yes to this? And primary care is devalued, and we need to do something about that in terms of pay, in terms of support, in terms of its importance in the system. So those would be the things that I'm thinking about. Broadband is essential, transit across Missouri to keep these pockets not isolated. The same issues that we're talking about in rural, suburban, and urban areas is important. And the last thing I'll say is I don't know if we have a Missouri identity. We have the privilege, maybe the privilege, of having so many different states that surround us. And identity is typically formed more by what you're next to in Arkansas or the school that's near you in Kansas than a Missouri identity. And that is challenging for us as Missourians to really get together to codify who we want to become. So I think we need to get together and really say, what is the Missouri we collectively envision? And no matter what your geographic location, can we share that to really make this state great?
Bethany, you have hit on a theme that this fellow from North Carolina discovered about 5 years ago when he came here. I had never been in a place that's touched by 8 states. And it does create an interesting challenge because they do, and it wouldn't matter where you were. If you're touched by 2 states, 3 states, whatever, you're going to be influenced by those borders. And when you're touched by 8, it does create an interesting dynamic. And the other thing that's a piece of that is how Missouri was settled as well. There's culture in that. And I think understanding that helps us get to having that bigger conversation you're talking about. So you've just given us a nice bow on this whole conversation today, and we got a minute or so left here. I'm going to go to Christy with one question. We had one particular question that came in. I think, Christy, you may be the best person to ask on this. We have extension specialists, people all over the state. They're running into people who continue to have concerns about taking the vaccine. And extension specialists sent this question, is there anything we can do to help inform them better, make better decisions, perhaps provide information so they'll make better decisions in the vaccine space?
The thing that's worked best in our community is going directly into their churches or organizations and talking to them one-on-one about their concerns. One of our physicians expressed it very well, is when the patient comes to him for another appointment, he talks about the vaccine. He doesn't try to bully them or force them into getting it. He really tries to talk to them about what their concerns are, and then explains, what the benefits are, talks to them about their concerns, and really tries to meet them where they're at so they can understand the benefit for them. So I would say that's what's worked best in our community. And I don't know if maybe Bethany has something for their community, or if the telehealth folks have learned something, or John, even in Northwest, but I know here in Central Missouri, it's really talking to people one-on-one about their concerns and trying to have them understand the benefit for them.
You hit on such a great point, and I have found the same thing, not only professionally but also personally, that it's, there's a lot of hype, there's a lot of media, there's a lot out there, a lot of information, but there's nothing to replace that quiet conversation with an individual who you have a relationship with, to say, I'm really concerned about you, your family, and let's have that conversation. I think what you have just described is so important, because so often, I think, again, the noise has cluttered what can be a meaningful conversation. I've actually seen people with that conversation choose not to get it. I've also seen people choose to get it. And I think it's something we all have to work on, be diligent in, and realize there's not going to be a flip of the switch that's going to change that. Folks, we're going to wrap up this panel. I could continue to talk to you guys for the next 15 minutes, but we don't have that kind of time. You have been phenomenal. I have learned so much. I've got a page full of notes on you guys and things I want to follow up with you on, and I look forward to the time that I personally can meet you personally, because we're looking forward to those opportunities to partner further. And I do want to thank all those who helped put this together today. I want to thank Bethany for her great remarks earlier, and then again rolling into the conversation here. It's been really good to really bring a good insight. Christy, Karen, Rachel, Melissa, and John, just can't thank you enough for all that you've done, and those key takeaways that at the end of the day, we're all in this together, and we've got to figure out, I thought there was a great comment there at the end about how we put Missouri first. How do we as Missourians come up with something that we can talk about that becomes our pathway forward as we think about what we want to be, what we aspire to be in the future.
We've talked about building our health infrastructure and our capacities to improve health outcomes. Now, let's take a look at what social determinants are driving health outcomes in your communities. Here to help us do so is Angela Johnson with the MU Extension Center for Applied Research and Engagement Systems. CARES, as it is known, is the data visualization and mapping arm of Extension work. After her data presentation, we'll hear from Nonprofit Missouri presenters Andrew Graybaugh, President and CEO of Missouri Heart of United Way and Nonprofit Missouri Chair, and Allie Chang Cray, Principal and Independent Consultant with Mutair Network. They're going to help us understand the variety, scope, and power of our nonprofit partners to help us identify critical areas of need and shape better health outcomes across the state.
Well, thanks everyone for joining me. As I said, my name is Angela Johnson. I'm with the Center for Applied Research and Engagement Systems, or CARES. If you don't know CARES, we are a technology and data analysis and visualization group with Extension, and we're the team behind All Things Missouri. Well, today I'm going to talk to you about the social determinants of health, and then show you how you can use some of our tools, which are available on All Things Missouri, to first explore data and then to find partners who are working to improve health outcomes in your community. So I wanted to just first start with a question, which is, should where you're born determine how long you can live? If you attended Dr. Proctor's Health Equity Keynote yesterday, or were listening earlier today, I think you might be familiar with this concept. We saw a version of this data for Washington, D.C. on life expectancy, highlighting disparities in life expectancy across neighborhoods. Well, the same is true in Missouri. In some parts of Missouri, individuals who are born less than 2 miles apart can have a difference in life expectancy of over 15 years. But why is that? Well, the answer, as we've heard, lies mainly in the social determinants of health. So these are, as you heard discussed throughout the week, the conditions in the environments where people are born and where they live. So social determinants can include those aspects really of an individual's identity, which we can't change, things like, age, race, gender, but it also includes a multitude of factors that are really rooted in community characteristics and community systems. So what do we mean by community characteristics? Well, there are probably hundreds of specific examples that we could give, which can be measured by things like unemployment rates, graduation rates, access to community parks, crime rates. So these are all examples of ways that we measure specific community characteristics that impact health. But it can be helpful to think about social determinants by grouping these factors into categories. And there are multiple frameworks out there which seek to do just that. But the model that we're kind of working from and sharing with you today is available from the US Healthy People 2030 initiative, and it groups social determinants into 5 categories. So in addition to those individual or household determinants, things like race, age, gender, community characteristics are grouped into 4 main topic areas, and these include economic stability. Refers to the ability to afford basic needs, and it's driven by community factors like employment and really the affordability and availability of things like food and housing. Education is the second community factor, driven by access to and the quality of community schools, ranging from early childhood education, things like preschool, on through post-secondary trade schools and universities. Healthcare access, we've heard talked about a lot this week. Refers to community level availability of providers, as well as we heard today, the financial or transit related barriers to obtaining services. And then lastly, kind of this broad category of community design refers to the physical environment, so how healthy is your air and water, as well as a broad range of community infrastructure elements, things like access to internet, access to roads. Can you even obtain those telehealth services we heard talked about just now? And then things like sidewalks, parks, etc. So with those factors in mind, I'd actually like to invite everyone to join me at the link, which I hope will be shared in your attendee hub in the chat box, to answer a question about the social determinants of health in your community. Maybe someone could also just chat and paste it into the chat box if you don't have the hub open. But specifically, the question is, of the 4 community-driven categories of social determinants that we just discussed, which do you think needs to be addressed most to improve health and well-being in your local community, based on your zip code or thinking about your county? My hope is we'll actually be able to look at the results of this little exercise by zip code in our map tools in just a few minutes here, assuming technology is our friend today. So take just a few seconds to do that. And while you're thinking and hopefully clicking around, I'll move on and share with you some of those new technology resources that are available to really help illustrate the linkages between social determinants and health outcomes. All right. So now that I've asked you to answer that question based on your own experience, what I'm hoping to do now is explore how we might use data to really support you in identifying priority areas, either geographically or categorically, to focus on our health improvement efforts. So if you head on over to allthingsmissouri.org, which you've heard talked about earlier today, you'll find a new button on our homepage. It was just added this week, labeled the social determinants of health. So clicking on this link takes you to a page where you can find a number of different technology resources, including, just to highlight, Explore Mo Health, which includes the zip code health rankings that were discussed just in the session earlier today. But clicking this link takes you to a page where you can find all of these resources, which include some new tools that were built just for this week, just for this session, as well as some existing resources that we've kind of bundled together on this page. So these new tools include reports, engagement guides, starter maps with access to great data to explore the topics we've discussed earlier, and also our story map. So what I want to do now is jump over to our newest story map, built again by the great team supporting me at CARES. Which is all about the social determinants of health. So our hope is that you could use this story map to present the concept of social determinants of health to others, or you can use it to explore data in more detail for yourself. So we start the story by, again, introducing the concept of social determinants. And on this front page here, you can also explore key data for indicators across each of those 4 community level social determinant domains, and really see how data vary by geography. For example, in our first map here, we're displaying trends in access to primary care physicians across Missouri by county. Counties are shaded by really the ratio of providers available per county population. The blue dots indicate the individual doctors or clinics, and you can really use this map to explore where in the state or within a geographic region issues of healthcare might be most extreme. So I think we see really clearly a lot of that urban and rural divide based on the density of providers. And we're not even talking hospitals here. These are just actual physicians. Just to orient you to the map a little bit, this little button in the top right-hand corner will populate a legend. So we can see our dot on the map there. And our secondary legend isn't popping up right now, but that should pop up too. But you can also click on each of the map counties, so there it goes, and hopefully see some attributes about the data in that particular county. And then the same is true if we have data for each of those 4 determinant domains, which you can access by clicking these tabs across the bottom. So if I go down to our financial stability and employment tab, we can see data about unemployment rates across Missouri. Again, clicking on a county, we'll be able to see that unemployment rate for a particular county. So again, the goal here is to really look at that regional variation across these social determinant domains. But as I shared earlier, there are, really any number of individual topics when it comes to these domains. And thankfully, we do have a resource for that on All Things Missouri, the Missouri Map Room, where you can access up to 30,000 different mappable data layers, some of which are available in a starter map gallery on the social determinants main homepage, and others which you can access by searching and adding things to our room. So in addition to looking at regional variation and specific social determinants, what this story map really does is highlight the relationship between social determinants and health outcomes. So I'm actually going to skip to our third chapter here. Our second chapter is just our survey, link to our survey. And in our third chapter, what we introduce is what I think is really one of the most helpful tools in identifying priority neighborhoods, and that is the Area Deprivation Index, or ADI. So the ADI is a composite measure of social vulnerability based on 17 underlying factors across those domains we talked about earlier. So things like poverty rates, things like unemployment, things like overcrowded housing. So this score is then transformed into a rank for each neighborhood based on a census block group relative to all other neighborhoods across the state. The neighborhood with a score of 10, so a higher score, has a higher level of deprivation based on those factors than a neighborhood with a score of 1. In the map, so here there are neighborhoods that are shaded in a darker purple have higher deprivation or than our dark green neighborhoods, which are ranked toward the bottom or ranked at 1. So across Missouri, again, what we can see is really a lot of regional variation. So we have a lot of areas of green across the center of the state. But then in our kind of dense urban cores, we see a lot of that dark purple. But what's really interesting to me is that within an individual county, you can see a lot of individual variation across neighborhoods. So there's not one county that's all green or one county that's all purple. Neighborhoods right next to each other in some cases have scores which are extremely disparate in terms of neighboring census block groups, but very different scores. If we but the question is, what I want to address is, what does this mean for health? Well, with this map loaded, if you adjust this bar here, which is a slider to reveal the map layer underneath, what we can see just that. So underneath this layer of area deprivation, we have a map layer that's ranking each of the 940 zip codes in Missouri with regard to health outcomes. So this is a mapped data layer that's from that Explore Mo Health zip code health rankings project we heard talked about earlier. So it's based on length of life and quality of life. And just like ADI, a higher number is bad in this case, indicating worse health outcomes. So what we see here, especially in some of our really disparate regions, is that our dark red zip codes indicating worse health outcomes really correspond to these dark purple areas indicating worse, higher deprivation with regard to those social determinants of health. What I really love about this slider tool in particular is if I go in and really drill down and click on a specific neighborhood here, I can see that ADI state rank, our block group 1 here in St. Louis city region. And then I slide it on over and my attributes change, and I can see that rank for the zip code health rankings. And again, out of a total of 940 zip codes. And then if I jump on over to, again, a neighboring zip code, neighboring in terms of proximity, our rank jumps by about 900 ranks. And then I can see also that our deprivation index score jumps to the top ranked neighborhood. So I definitely encourage you to, explore this data. What does that look like for your area? What relationships can you see? What areas can we prioritize in terms of those social determinants? But also want to move on to our next chapter to kind of continue to explore that concept of health disparities. So just as you saw kind of in the previous example, the relationship between neighborhood social determinants and health outcomes, I want to take just a minute to further explore with our data here, the issue of disparities in health outcomes. So we've talked about this before in the earlier example in the slideshow and yesterday in our session. But here we can, again, really dig into that data for your particular area. This is a map that's just showing life expectancy across Missouri by zip code. So earlier we asked the question, should where you're born determine how long you live? I think we can all answer no to that question. We're all actively engaged here to try to reduce those disparities in geography and race, ethnicity. But this variation by zip code clearly does exist. And just to restate, in some parts of Missouri, individuals less than 2 miles apart, in this case, have a life expectancy difference of around 15 years. So there, and this relationship isn't just true, in St. Louis and Kansas City. There are other parts of the state where we can see really clearly those areas in dark blue right next to areas in orange or red. And you can really use this map to explore that data for your particular area. Again, clicking the map brings up data for specific zip codes, so you can see how it varies in your particular region. And just as an aside, in the Missouri map room, we have this data too available for every neighborhood in the US. I know a lot of the times, especially for those working in our urban regions or across the state, there are bordering communities outside of the state of Missouri that we might want to explore. So that is available to you outside of this story map instance. But, again, this is a clear example of health disparities present across geographic areas. But if we go to explore the relationships between this data and our social determinants, we can see, maybe a reason for why these disparities exist. So going into the text part of our story map here, I want to highlight that the data can show that. So the chart that's below here, if I click it, it will kind of pop up and expand to show you, summarizes life expectancy in Missouri across the top or best and the bottom worst neighborhoods according to those social determinants based on those ADI, area deprivation scores, that we just showed in the last chapter. And what we can see is that the best ranked neighborhoods for social determinants have, across those best ranked neighborhoods, life expectancy is more than 4 years higher than in our bottom social determinant neighborhoods. So really, again, just kind of showing that trend is present and apparent based on geography, based on those social determinants. So not only based on geography, but looking further back at those social determinants. But we also just do need to remember and call out that life expectancy also varies in Missouri by race and ethnicity, by our other identities, and these are intersectional identities. So where we live, who we are, who we love, what our disability status is, those all come into play. But we wanted to also particularly call out that really it's that same level of disparity. So we have almost a 4-year gap that exists when comparing the non-Hispanic white population and Black populations, again, in Missouri. Now, research shows that much of this variation can be explained or accounted for by variation in individual socioeconomic status and neighborhood conditions. However, does not explain all of the variation. So some disparities in life expectancy in things like pregnancy and birth outcomes do exist even when controlling for neighborhood conditions, individual income, individual educational attainment. So issues in racial equity, as we heard yesterday, as we heard today, these can be rooted in really deeper structural disparities that transcend community conditions. Our data and maps don't really show that, but I did want to make sure we acknowledge that and call this out as we're discussing these issues of community conditions as well. So the point is that improving community conditions can make big strides in reducing these disparities, and that's really what we're talking about today. So again, if you want to spend more time with this data, you can either use this story map here to look at the issues across Missouri, or you can access our data through the Missouri map room and that All Things Missouri Social Determinants landing page. Moving on to the next chapter of our story, let's look at the results of our survey. So we've had 35 participants respond. We'd love to get that engagement a little higher, but that's great to see that we've got some responses here. And again, you can access the link to that survey in our second chapter. But looking on down here, we see that, there's some variation in what folks are identifying as the top priorities for their particular areas. Financial stability and employment we see is really rising to the top, and that makes a lot of sense considering all the discussion we've heard today and this week around issues in healthcare, employment, and provider availability, as well as issues in finding secure stability jobs. We think about employment as being a way to access high quality health insurance and ability to afford childcare, to find you time to do other things. But all of these issues are really interrelated. The point for this survey is really there's no wrong answer, but we just wanted to look at some of these data, see how folks are responding, and collect the data to see where there's consensus, where there isn't consensus around these community issues. So again, the link to this survey will remain active in the story map. If you want to share it out with your community members to either further demonstrate the concept or to just share the data, you can certainly do so, and we would encourage you to do so. So we've talked about social determinants. We've seen the relationship between social determinants and health outcomes. So the final question is, what do we do about it? How can we address these social determinants, reduce disparities, and improve health outcomes? Well, we hope to address some of that in our last chapter here on nonprofits and community health. So we've heard a lot about the way that groups across Missouri and within Extension are doing that. But what we want to point out, and what's interesting to me, is that when we think about improving individual health still, we often look to places like hospitals and clinics, because at the individual level, that's where it's most visible. That's where healthcare is happening, right? That's where we go to treat injuries, receive treatment for disease, where we get our, immunizations and medications for the most part. But there are, of course, many other players in the health improvement game who are working behind the scenes at a population level. And this diagram might be new to some. It's called the Health Impact Pyramid. And it states that improvements that happen at the bottom of the pyramid at the community level have a bigger impact on population health than those at the top in the clinical realm. So we've heard about some of the ways that university and extension are chipping away at the social determinants and working to improve health equity throughout the week, as well as our other partners. We're doing things like recruiting more rural health providers and helping employers support recovery-friendly workplaces. But outside of the institution, as we've seen demonstrated, there are lots of other partners who are working at the bottom of that pyramid. And you could say that those who may be having the biggest impact on health are nonprofits and community organizations. So if you spent time exploring the attendee hub at all this week, you may have seen that there was an exercise which asked you to identify up to 5 nonprofit organizations working in your local communities. So if you didn't have a time to do that earlier, just, you could think about that for a minute now. And, for some of you, it might be easy, but for others, it may be a challenge to know who's already working in that space. I know it would be for me. So to help us all kind of better understand that landscape, what we have done, although my points aren't showing up on the map right now, so it's a little hard to demonstrate, is what we've built is this nonprofit explorer. And what the goal of this, oh, there they go. What the goal of this is to allow you to look at the locations and characteristics of nonprofits, which in this case are based on their tax exempt status as a 501c3 or 501c4 organization. It comes from the IRS, and the data is actually current as of this month. So with this Explorer, what you can do is you can select to view data for the entire state of Missouri, or you can go up to the top right corner and select a county dropdown to start exploring and looking at nonprofits working in your county or region. So if I go up and select Berry County, for example, my chart changes, my data changes, and I can see that there are now a total of 170 organizations with nonprofit status working in or located in Berry County. This chart out here lists the top 5 organizations by their reported income in our data set, which isn't available for every organization, so just take those with a small grain of salt. But I should point out that we can also see the primary category code of the organizations here, and then we can actually go in and click on the particular locations in our map and start to see attributes such as their name and then those description codes, so what areas they're working in within our map. If we switch to Boone County, for example, my data will change again, and I'll see there are close to 1,000 different nonprofit organizations working in Boone County in the nonprofit sphere. There we go, it's relocating also. So that's the story of our social determinants for this story map. And what I want to do is end by challenging us to think about social determinants and community change work as health work. And as others have stated, to keep our perspectives broad in terms of who we might reach out for partnerships when pursuing health improvement work. We've heard a ton about how economic development is health improvement work, housing is health improvement work, early childhood education is health improvement work, faith-based organizations are doing health improvement work. So that's it for my presentation. I hope you continue to explore these data and resources, and I'm going to turn it over to Andrew and Allie to continue this conversation and talk about some of the work nonprofits are doing in Boone County and the impact of nonprofits on health.
Okay, great. Well, thank you so much, Angela. That was excellent. My name is Andrew Graybaugh. I'm the president at the Heart of Missouri United Way in Central Missouri and the chair for the board for Nonprofit Missouri. Let me just start out by saying one thing about nonprofits, right? We saw Angela's amazing slides. Nonprofits have organizational limits, capacity limits, and so that means I put my slides together. So I ask for some forgiveness and grace as you look at what we're going to present as we talk about the role of the nonprofit sector in Missouri and how it intersects with all of the work we do around throughout the state around the social determinants of health. And so I wanted to jump right in and move to the first slide that really moves forward this idea as we talk about the social determinants of health, that one sector and one organization can't drive all of the outcomes. It's a team effort and with multiple players, and the nonprofit sector's role in Missouri should be a part of those conversations and decisions. You'll hear more about the statewide role in a little bit from my colleague Allie, but I wanted to start off with an example of Boone County and how nonprofits work across sectors and provide an important part of helping to improve our community's health. As you can see from this slide, food insecurity is an issue that's found throughout the state of Missouri. And in fact, I grabbed this data from All Things Missouri, and you can see that in Boone County in particular, 15% of our citizens are identified as food insecure. Now, we know the health issues that are connected to food insecurity, and we know that it's an indicator linked to poverty, which contributes to overall poor health. Clinical care and healthcare providers have solutions connected to these health outcomes, and there can be challenges with improving patient and client care outside of the typical clinical health domain. So this is something of a last mile issue, and this is where the nonprofit sector can really come in and help and collaborate in advancing the health of our community. One way to address this is through the engagement and the collaboration of the nonprofit sector by looking at data somewhat differently. The nonprofit sector can be a last mile solutions partner by looking at the social determinants of health and looking at different types of data to develop programs that leverage their existing capacity for service delivery for helping our citizens, with the ultimate goal of still achieving those larger community health outcomes. So if we look at food insecurity again, we know that poor health outcomes are associated with food insecurity, such as heart disease, obesity, high blood pressure, etc. Now, those health outcomes are long-term measures. But in the nonprofit community, we can look at short-term measures like fruits and vegetables consumption and how that might be telling us a slightly different story on how food is accessed and how food insecurity perhaps persists throughout the state. And so the nonprofit sector can use data like that in helping to add specific value in coming up with programs and ideas and solutions to advance and to help our community as a whole. So if we look at the next slide, you can see here in Boone County, just to continue this example, that we look at all kinds of data. In particular, I wanted to share this slide on fruits and vegetables consumption as reported through the Boone Indicators dashboard. This dashboard is a collaborative project between the City of Columbia, Boone County, United Way, and the University of Missouri's Institute of Public Policy. When we look at data like this, we can begin to think creatively about programs with short-term measures that will have long-term health outcomes and impact. So in this example, our nonprofit community is working with the Boone County City of Columbia Public Health and Human Services Department, the University of Missouri Health System, the Heart of Missouri United Way, and MU Extension. We're also looking at local nonprofits that are helping to lead the way, including the Food Bank of Central Missouri, the Columbia Center for Urban Agriculture and Sustainable Farms, and others, including them, to convene around this idea that making data-informed decisions and partnerships can help us in reaching kind of that last mile. So, for example, MU Healthcare has formed a food insecurity coalition that has brought many different organizations from multiple sectors together to help address food insecurity challenges. There's a program, like for example, called a prescription food program that provides food to families through their medical provider, much like a medical prescription or a normal prescription. United Way here, Heart of Missouri United Way, has secured 2 AmeriCorps Vistas that will join us in 2022 to specifically address the systemic barriers in BIPOC communities around food insecurity. Another example of a program that exists through this collaboration is the extension of and use of SNAP dollars to be used at our local farmers market. Another is to look at establishing healthy food centers at medical centers. And then yet another is to look at a program that establishes community gardens at the Columbia Housing Authority and Columbia Public Schools. I share these examples because all of them are aligned around local data and work together collaboratively to help make sure that we're working together and advancing short-term measures with the goal of long-term impact. All of these are program solutions that can have a positive impact on those in this example that are suffering from food insecurity. So our community is mindful of both the need to look at short-term measures and long-term and how the nonprofit sector can intersect in those areas. And we believe this collaboration helps us in being a last mile partner to really help drive and improve the social determinants of health in our community. So with that in mind, I know Boone County is special to me, but I know it's not unique throughout this state. And we know other counties across the state are doing really fantastic and wonderful work through innovative programs that interact with the nonprofit sector. The nonprofit sector in Missouri is vibrant, as Angela shared. And so to share more about the vibrancy and that continued work, Allie is going to speak for a few minutes. So can I turn it over to you, Allie?
Thinking about that triangle, that pyramid that Angela shared right at the very bottom, addressing socioeconomic factors, Angela said that there is a great opportunity between our nonprofit organizations and our community organizations, right? Those are community-based. And so when we look at the abilities that that sector has to be able to help influence and drive that change from the bottom up, just as that pyramid showed, we see that in Boone County, that Andrew was just talking about, that the nonprofit sector actually makes up almost 11% of the workforce. When we look in Kansas City comparatively, it's 6.9. When we look in St. Louis, 13.3. Across the state, 10.8. And in the United States, 10.2. I point all this out to say that the nonprofit sector employs the third largest workforce in the country. The third largest workforce in the country. And so when we look comparatively in these other, what we call larger shares, right, that you might find in construction, manufacturing, or finance, like this is pretty darn significant. And so if we are looking at whether it's the last mile that Andrew just referenced or the bottom up that the pyramid points us to think about, right, there's a lot of opportunity here. So I want to go on to talk about then, again, the strength of the nonprofit sector. So Angela had this stat, if you were looking at the maps, right, she had a map that indicated the number, right? So just as a reminder, we're at 30,206. I mean, and that number fluctuates every single month, but you can pull it actively from the IRS database, just as Angela alluded to, right? But if we look at those that are 501c3 specific, right, and that does include some religious organizations as well, we're still at 28,000. Right? So it is pretty significant if we look at the possibilities of all of us trying to figure out some way, right, to be able to collaborate and using data as a connection point. Let's move over to the right side of the slide where we talk about the economic impact, right? So when Bethany was speaking earlier today in her keynote, she raised three different areas. She talked about education, health, and economy, right? So if we could bring this back to the economic impact of the Missouri nonprofit sector, again, we show that we're not only employing 10.8%, close to 231,000 people, but let's look at then how much money we're helping to put into Missouri's economy. Right, so $46.3 billion, right? That's annually. That's a lot of money that we're helping to drive in and out. Right, we hold assets of $86.5 billion. So these assets come in all shapes and sizes, right? Including real estate, including other ways in which we are able to accumulate and sustain our infrastructure as well, right? But like, we're not here for the short term, we are here for the long term. Our assets prove it. When we look at the foundations alone, right, and what that philanthropic impact is, they're giving over $784 million a year, right? And then when you think about what Missourians are doing as part of this landscape, our citizens are contributing $2.8 billion, right, to our charitable organizations each year, which represents 4.4% of household income. So again, these are all pretty substantial numbers when we take a step back and think about the possibilities, right? If we were to better connect with one another using the data to be able to address some of our largest social problems.
So this is also from Angela's information, but this may look familiar to you, where she encouraged us to take a look. I think it was, I don't remember which slide it was in her storyboard, right? But I thought this was fascinating to get a visualization of where the concentration of nonprofit organizations are. So despite the fact that it also shows, as Marshall referenced in Bethany earlier today, that there are 8 states surrounding Missouri, and you can, in this snap, see how that looks, so those concentrations on the Kansas side. If you look over there on Illinois, right, we know where there are rivers there and that we're crossing over. But even if you look in North Arkansas, right, there's a cluster right there that's on the border. So we can study that a little bit more. But what this map points out to me is the collaboration opportunities, right? That it's not only that as nonprofit organizations, if we take and share the viewpoint that healthy choices that our citizens can make will not only eliminate their health disparities, right, but will also be able to address the inequities that we see that prevent access and opportunity for everyone. And so how can we do that? If we look at health data, right, that can actually be a starting point for having conversation about the collaborative efforts. We anticipate over time that there's going to be available federal dollars that are going to be more closely tied to the social determinants of health-based outcomes. And I say that because not only do I serve as a consultant to Nonprofit Missouri, but I do consultation work across the state of Missouri and nationally as well. And I can tell you, from private foundations to federal departments, agencies, and offices, right, that are all involved with giving charitable dollars, that is a trend that's picking up speed. We have seen in certain topics and issue areas where we can invest a lot of money over time. And some of these issues are really large and involve quite huge shifts in our systemic approach to how we address them. But if we look at the social determinants of health and how they wrap around these issues, that everything is very interdependent and interrelated, we see that there are actually some shared measurements that if we were to put our combined power behind those, we'd actually be able to start to move the needle on that. And the social determinants of health provide a roadmap to assist us in doing that. One thing that Bethany shared earlier today that I want to offer is this idea of trust in communities. And so this is actually a extraction of a report that's done from an international communications firm called Edelman. The corporate sector actually depends quite a bit on what Edelman has to say, but you can see that Edelman not only tracks what's happening in business, but also tracks across other institutions. And so in this particular slide, we've got business, government, and media. For us, NGOs, it's also nonprofits. Again, Edelman is an international firm. And so globally, our work that we know as nonprofits or community-based organizations are frequently referred to as NGOs. And so that's how it's reflected here. But if you look at the indicators of the colors, so red, distrust, fortunately, we don't see red amongst here, but we do see a lot of neutral. And then we also see that, interestingly enough, business increased by 2 points since the last time this survey was distributed. And so what I want to show this is that, again, when we look collaboratively on what we are trying to do for our public and to increase health, there is an opportunity here between business, government, and the media, right? And the nonprofit sector, along with others, are very central to that messaging, to be able to come together around some of these issues and topics. And again, data allows us to do that, but it's not only talking about the data, right, as a conversation starter, but it is using it as a tool to be able then to partner to determine what solutions might be, right? And if we use that bottom-up approach from the pyramid and we start recognizing that nonprofit organizations and other community-based organizations know best because we are in the neighborhoods, we are working closely with the people, right? We are able to then take the data we collect at that level and move it up. And as Angela said, eventually reach population level success, but it takes very deep grassroots work to be able to do that. And so that's something then where if we're able to work in collaboration together over time, we hope that we'll be able to increase the trust of the public. You know, when I listen to the results of the Gallup poll, it's disheartening at times, but it also provides me hope, right? Because we can do better. We heard Marshall say that. We heard others say that this morning in the panel. And so this gives us an opportunity to do that. So before I get ready to pass it over to Andrew, I want to just reinforce then that what we have the opportunity with at the state level, even if we choose something like the topic of unemployment or food insecurity, right, whatever the issue may be, probably one of the first steps that we want to do is not only look at the statewide data, but then just like as Andrew showed with the Boone County data, pull that then down to what's in our neighborhoods, right? And then look at that comparatively. So whether you want to do that with other communities in Missouri that have similar population, other similar characteristics, or you just want to see how you fare with others. So in this case, we were comparing Boone County to Kansas City to St. Louis, and some would say, wow, is that a fair comparison? But when you looked at the percentage of employment in the nonprofit sector, Boone County was right up there with St. Louis, right? It was actually in that example, Kansas City that was behind Boone County. So again, there's lots of stories that we can tell from the data, but let the data tell the story, right? And that's where we begin the conversation so that we can move into partnership, so that we can better collaborate, and so that we can influence and achieve better health outcomes for all our citizens in the state. Andrew, I'm going to turn it back over to you.
Great. Thank you so much, Ali. Yeah, I agree. The attempts to bring the nonprofit sector together statewide has a lot of opportunity, not only for us to better tell that story, but really just to be mindful of how we utilize the services that are bestowed either through grants or donations in having the greatest impact throughout the state as possible. And you know, one of the ways that's been done is through Nonprofit Missouri. And I know there are other statewide attempts as well, but Nonprofit Missouri was formed in 2010 and has served as kind of that collective voice to unite and strengthen and advance the nonprofit sector throughout the state of Missouri in helping to advance advocacy, have that conversation, and to just advance capacity building knowledge so nonprofits can be as strong and as impactful as possible. And so with that in mind, though, if we can just go to the very last slide, I think there should be an effort, even though we need to seek out collaboration on a statewide level. One of the messages I think from today that should be one of your takeaways is that we need to convene on a local county level. And when nonprofits work together and collaborate with other stakeholders like MU Extension, county health departments, healthcare partners, all stakeholders across the board, when we all do that together, we commit to improving the state, and we see that through finishing Missouri's business. And when we do that and pursue that as our goal, it can become a reachable goal, making our whole state better. So I hope after today we all feel inspired to do that and can commit to building these connections together. Thank you very much.
Thank you, Andrew, Angela, and Ali for your presentations this morning, still morning. You've really helped us understand better how social determinants affect community and individual health, and how critical partnerships with nonprofits and education leaders are to addressing inequitable health access and outcomes. The challenge is then, how do we get involved in enhancing health and well-being in our communities? Our next session features a call to action that will help you explore the knowledge and tools needed to make a difference where you live and work. Thank you to both the Missouri Hospital Association and Hush Blackwell, today's event sponsors.